You can do an MRI and find out whether it is Conus or Cauda. That is different. Neurological differentiation of Cauda equina syndrome, which is standard way of called a CES, and Conus medullaris syndrome called the CMS. Okay.
Okay, sir.
So neurologically, how to distinguish? You can see the diagram there, handwritten diagram. The red part is the cervical cord. The yellow part is the thoracic cord. The blue part is the lumbar cord. Okay. And you can see here the conus. Okay. A little bit projection like thing. That is the conus, and the horse tail is the pink or the purple part. Okay. Now, as you all know, there is a distinct difference between the vertebral level and the spinal level. Vertebral levels do not correspond to the spinal cord levels. Why? Because the spinal cord ends exactly between L1 and L2. And the roots are continued like the tail of a horse. That is called Equinus is horse, Cauda is tail, Cauda equina. So L1 and L2, the spinal cord terminates. This is the level of the L1 and L2 here, and the filum terminal continues down to the end and gets anchored there. What is the use of that filum terminal?
It is the terminal portion of the spinal cord, sir, with only pia matter, sir.
There is no neurological matter in that, and no nerve roots, no spinal cord, only the fibrous part is there. This is to anchor the spinal cord. Suppose you have a belt, you want it to be completely stretched. What do? You put some weight and fix the lower end so that the spinal cord is just stretched and kept, not overstretched, not allowed to withdraw itself higher. So if that filum terminal is not there, what would have happened is the spinal cord, if it by any reason little bit shrinking is there, the nerve roots are through the different foramina and they will be compressed. So that is the reason God has given a very anchor there, the filum terminal. The use of filum terminal is to fix the spinal cord and keep it sort of stretched and erect there. That is the reason for spinal cord. Filum terminal is there. So you have at the L2 level, the dorsal roots are coming, L2 dorsal roots are here, L3 dorsal roots are here, L1 by L1, the spinal cord ends and the S1 roots are coming somewhere there. Okay. So the discrepancy chart also is given in cervical. There is no discrepancy. As you go down the vertebral level compared to the spinal level discrepancy, you can see that. So now let us look at each particular aspect. And this part, conus medullaris, is a very compact part. Is it upper motor neuron or lower motor neurons in conus?
In conus, upper motor neuron, sir.
It is still the central nervous system. It is still the continuation of the central nervous system, the cord only. Whereas Cauda equina are the roots, and the nerve roots are there. The lumbar plexus are there, and it is a lower motor. Okay, lower motor neuron is the Cauda equina. Upper motor neuron, basically upper motor neuron, and a little combination of mixture also can occur, because at that time there at that area of L1, L2 where the conus is there, there are some lumbar roots also are there. So it could be a little lower motor neuron with upper motor neuron combined when you have a lesion of the conus. But conus per se is the central nervous system component, whereas the Cauda equina is PNS, peripheral nervous system component. That is the basic understanding. Now, so this I'm circulating, keep it as a guide for you, and this is the way you should be able to just sort of rattle up the answers. Cauda equina syndrome is L2 to sacrum. This is L2 from here, L2 to sacrum. That is the involvement, whereas conus medullaris is L1, L2 level. That is, the level is very different. Can be any L2 to sacrum, any root can be affected depending upon, suppose there is a compression at the level of L5, only the upper roots are spared. There is a compression at L3, L1, L2 are spared, and then the lower roots are affected. So it can go on from L2 to S5, any roots may be compressed. Usually L2, L3, L4, L5 are the roots affected in the Cauda. In the Conus, it is at the level of L1, L2 vertebral level, and this is an upper motor neuron type. The lesions can be compressive, can be ischemic, can be inflammatory, can be degenerative. So give me an example of each one of them. A compressive lesion can be intradural or extradural. Intradural, you said meningioma. Extradural, Pott's spine. You can say. Ischemia. What is ischemic compression? In ischemic involvement. Anterior spinal artery or posterior spinal artery thrombosis. Inflammations can be there. Inflammations due to arachnoiditis or any other thing. Degeneration, myelopathies. Okay, myelopathy will be degenerative, and compressive, ischemia, inflammatory, degenerative. These are the features in both, but here it is mostly inflammatory or degenerative or ischemic. Intramedullary compressions are rather rare. Okay. So lumbosacral region segments are affected, spinal cord segments, sacral cord segments are affected, maybe roots, lumbar roots at that level may be affected. In that case, it becomes mixed. So sacral cord segments are mostly affected because this the conus is a compact part of the spinal cord representing all the sacral segments. Most important thing is, as we have brought out today, in the case it is asymmetric, dorsal roots may be affected, ventral roots may be affected, fibers may be affected. It is very compact and symmetric in case of conus medullaris syndrome. Here, greater lower limb involvement because L2, L3, L4, L5, S1, S2, these are all subserving the lower limb. And there's a greater involvement of the lower limb here. But here, all those segments are not available. Only the sacral segments play a very small role in the lower limb compared to the lumbar segment. So you may not get a very extensive lower limb involvement. But these sacral segments take care of the bowel, urinary bladder, and sexual function. So the early onset of bowel bladder sexual dysfunction is a feature of the conus medullaris compared to Cauda equina, where they may occur if the sacral segments are affected but quite late in the illness. Muscle weakness is very pronounced because of the extensive involvement, more and specific to the roots involved. Here we have seen that is wasting and fasciculation of the posterior thigh region, says that those roots are the ones which are involved. It could be dorsal root or it could be ventral root, it could be the anterior horn. There is no anterior horn cells there in the Cauda equina because spinal cord has already ended, but the weakness and the root involvement is the cause for fasciculation and wasting. Whereas here, the motor weakness is rather there, but it is mild and it is the central nervous system type of motor weakness. In general, peripheral nerve involvement, the motor weakness is pronounced. Central nervous system involvement, motor weakness is rather less pronounced. And the recovery of the motor weakness in central nervous system is quite good, whereas in the peripheral nerve is involved, peripheral nervous system is involved, the recovery is rather poor. Whatever physiotherapy you do, you may not get back the muscle tone and power. Whereas in CNS or physiotherapy over a time, there will be functional improvement is possible. So lower motor neuron lesion, this is typically an element type of lesion where you have wasting, fasciculations, hyporeflexia, and then the hypotonia. What are the four important areas in terms of muscle power? Power is decreased. In terms of tone, it is hypotonia. In terms of nutrition of the muscle, it is reduced nutrition or wasting and fasciculation. And also you have So wasting, fasciculations, hypotonia, and then low power, and then low DTR or decreased DTR are features of lower motor neuron lesion. Whereas upper motor neuron lesion, fasciculations are not a feature, wasting is not pronounced, hypertonia is there, hyperreflexia will be there, and then power is rather reduced, but not to a great extent, whereas in lower motor neuron, power is very much reduced. So that is important. And here in Conus, we can have CMS, we can have UMN and upper LMN mixture, because if the lesion is somewhere here, it can involve the conus and the adjoining lumbar roots also, in which case you can see a mixed picture. Okay, now sensory, coming to the sensory, asymmetric sensory loss, symmetric sensory loss, saddle anesthesia, little rather late feature as we have seen in this case, typical saddle anesthesia to start with, and LMN features decreased DTR, hypotonia, UMN features increased DTR, hypertonia, bulbocavernous reflux is lost, Babinski reflux is lost. Here bulbocavernous and Babinski are not affected because these reflexes are not served by those segments. Bladder, bowel, and sexual function. Late in occurrence, bladder, bowel, sexual dysfunction. Very early and severe. The type of bladder is a placid bladder, retention with the overflow. That is what your patient is telling. He used to have dribbling. He used to have difficulty in emptying the bladder, and hyperactive bladder with, overreactive bladder. This is a hyperreflexive bladder. So one day we will discuss the hyperreflexive bladder innervation and things. So we'll find a date. If you have a bladder case, you present it on that day. We will have. You go to urology department. They will be having several cases with the neurological reason for bladder involvement, and pick up one case, one of you. Not always they should present to your medical wards. They will be presenting to the urology department, thinking that the problem is urological and not neurological. So such a case you pick up and start investigating that. We can discuss about the bladder. So this table containing around 7 plus 7, 14 levels of differentiation of Cauda, Equina, CES with Conus Medullaris is very important for all of you as postgraduates. You should be as thorough as these 3 slides. And you must have a mental picture of the spinal cord and the segments and what is drawn here. These 3 slides are a summary teaching for this one. Now also you have to know that, in the spinal cord, if it is involved here, and the cord has got the anterior horn cell and the posterior horn and anterior horn, and the muscle thing comes from the anterior horn. This is the lower motor neuron, and it could be at the level of the myelopathy, and then the radiculopathy, that is the nerve is involved. Then the lumbar plexus involved, it is plexopathy, then the peripheral nerve, femoral nerve, like that, individual nerves, and finally at the neuromuscular junction, myelo, radiculo, plexo, peripheral nerve, and NM junction, and last one will be the muscle itself. So that is myopathy, neuromuscular junction and myopathy. So you must have, as postgraduates, what will be the features of one myelopathy, to root involvement radiculopathy or plexopathy, peripheral nerve involvement, NM joint and neuromuscular junction, and then the muscle involvement. You must have a very clear idea about the features of each one of these. So again, the myelopathy, when it comes to, it could be non-compressive myelopathy or compressive myelopathy. Non-compressive myelopathy usually transverse myelitis, compressive myelopathy from outside, from inside. From inside, like syringomyelia cysts are formed and different tracts are involved, the asymmetric involvement. And then the dissociated sensory loss is a feature of syringomyelia. Whereas when it's compressive myelopathy, it could be a vertebral fracture, it could be a disc prolapse, it could be metastasis, it could be osteomyelitis like tubercular osteomyelitis, parts spine meningeal tumor, both malignant and benign like meningioma. It could be arachnoiditis or any one of the meningeal inflammations, meningitis, and then subdural hematoma and subdural abscess, and vascular involvement produces mostly the from within the cord is affected. So this is one area: compressive, non-compressive. Non-compressive vascular and transverse myelitis. Compressive from outside, from inside, syringomyelia and Brown-Séquard syndrome, things like that, and subacute combined degeneration. These are the ones. Vertebral fracture, vertebral disc prolapse, metastatic deposits, osteomyelitis of various causes, common being tuberculosis, meningeal involvement, tumors, both malignant and benign, subdural hematoma, and subdural abscess. Last time we saw how the subdural abscess should be differentiated from other conditions. So these are the very important ways of understanding. So you should have a very clear picture of myelopathy, radiculopathy, plexopathy, peripheral nerve involvement, NM joint, and muscle. The exercise for today is write these 6 levels and write 5 points for each of them so that you remember how to differentiate myelopathy from radiculopathy, from plexopathy, from peripheral neuropathy, NM junction, and myopathy. Okay, that is the exercise. Last time I gave an exercise. None of you tried to write and share it with me. The best way of learning is trying to put on paper. If you start writing, then you will remember.